Okay.
Are we on?
All right, we're back, folks. We apologize for the brief delay. I got a message saying the name is Deion Sanders, but move on to this. We're talking about...
Time is his name.
Yes, we're talking about, thank you, Georgia Cancer Specialist. Apologize for a little technical delay. Got it straightened out. Things do happen, but move on.
I want to say that our aeronautical engineer went over there and plugged and unplugged stuff. I'm so technologically challenged. I sat here and sipped my...
Well, you want to know something interesting really quick, and we'll get back to your question. In the 10 years that I've been streaming programming, every once in a blue moon like this, when you have a technical error, you can literally unplug and plug back in, and don't try to figure the answer like what went wrong, okay?
But that didn't work. You had to do something else.
Unless you go to the blue screen of
You
death.
went to something else.
Right, so we're okay. Moving right along.
Put up the first one here, the fingernails. Ray and I frequently talk about the lost art, excuse me, of physical diagnosis. That's the first sign.
We've talked about how you have discussed that you could actually diagnose certain things by looking at a certain fingernail, how it's curved, and different things.
That's called clubbing with lung
Right,
cancer.
but you can actually look at somebody's fingernail and see different things.
Correct. And so Ray and I look at the fingers. They don't even teach this anymore. But iron deficiency can give you vertical lines in your... So I figured since we were talking about iron, I'd show that to you.
Bill, there's the further complication that most of the ladies I see nowadays, you can't get to their fingernails.
I'm not going there, but you're exactly right. All right.
Easy there.
Got the next one? Well, this guy here is not suntanned, okay?
No.
That bronze color is iron pigment in the skin, and hemochromatosis that has not been treated when there's a high iron level looks like that. Go to the next one.
How do you define that versus like jaundice? When you're looking at somebody,
totally different. Jaundice is a yellow.
And this is what?
Is a brown tanning.
Bronze.
Okay. But let's assume that you're like me and everything that looks anywhere between pink and red is pink and red, and you're not my wife who says there's 150 stages of white.
Right.
You do a blood test or you feel the liver or something. We have more than just looking at the skin. So the next one, hemochromatosis. You'll remember this is iron loading, and it can cause arthritis. It can cause diabetes, it can cause heart failure, liver failure when this iron gets deposited in an organ. Get up the next one. Now, just so that you'll know that this is a lot more complicated than I usually try to make it. My wife accuses me, if you ask me what time it is, I tell you how to build a watch.
What do you think? I just met you.
It's this next cartoon shows the very intricate interrelationship of iron to virtually every organ in the body. So too much iron, heart failure, diabetes, skin changes can ruin your kidneys. Pull the next one down. You asked how you tell something. So Ray does a blood count. With just the blood count in front of him, he can look at red blood cell size, distribution and so forth, and he can make a preliminary decision in his head about what kind of anemia somebody's got. Now, when you're doing an iron test, you've got lots of different things you look at. There's a storage iron, there's the capacity of the blood to store iron, that's called iron binding capacity. There's how much iron's in the blood, what percent, so there's a lot of that stuff. Pull that down now. So the therapeutic goal of thick blood, remember molasses in January, is to get the elevated red count percentage down below 47. Above 47, then the flow characteristics, that's blood rheology, goes down. You become sluggish, you become fatigued, you can clot. So you draw blood off until they become iron deficient, remember? And then you keep them iron deficient. Anytime their blood goes above 47 or 50, you take another bottle. I tell people, go to the Red Cross and donate. Don't tell them you got polycythemia, because if you tell them, they will take your blood, because that's inexpensive, and 3 people get benefited. One of them gets platelets, one gets red cells, one gets plasma, and your insurance company doesn't get a ridiculous charge from the doctor's office. But anyway, so this guy's been being treated that way. Something's going on. He's bleeding from somewhere. But the question is, how should he be treated for his iron deficiency, which was therapeutic? And as he began to bleed, probably from an ulcer or something in his colon, he did not have storage iron to keep up with it because of the treatment of hemochromatosis. So the therapy.
So bottom line is, he was running relatively low iron.
Very
and
low
when he had
iron.
something else kick in,
Right.
it sucked the rest too
it
much
was-
iron out of him.
The
So-
iron was therapeutic for him. Low iron was therapeutic for him. Now you got to give him back iron, but you don't want to give him too much iron. So anyway, they signed him up for IV iron. Here you go. This is about the advantages and disadvantages of taking an iron pill versus an iron infusion. And virtually today, iron pills are rarely used for any significant degree of iron deficiency anemia. Now, when you've got a menstruating female with a modestly low hemoglobin and the iron is low, then oral pills are the answer, or prenatal vitamins or whatever. But if you've had an ulcer or malignancy or some significant iron deficiency, one, you can only absorb a small amount of iron regardless of how much you take, and that's 18 milligrams per day. And the smallest pills they sell are 65 milligrams, and then people, the label, if you get over the counter, says take 3 a day. That gets you up to almost 200 milligrams. And 80% of people taking oral iron in therapeutic doses are nauseated. So the disadvantages of oral iron are, starting right off, gastrointestinal side effects, right?
Mm-hmm.
All right. What does the next one say?
Compliance may be low.
Yeah, that people aren't going to take a drug that's making them sick, right?
Right.
Well, now, as I told you before, if you give somebody a shot in their fanny, they took the medicine. Some of our antibiotics make you nauseated. So guys in Ray's office, he's sick, he wipes him in the fanny with a big dose of antibiotic. The guy got it, and then you don't have to worry about it. So that the advantages to IV iron are, patient gets it, and 2, you can give all the iron that's going to be required to replace the iron stores in a couple of infusions. So it is by far the most effective, it's safe, and in the long haul, it's actually cheaper. Long-term oral, Integra, those drugs, cost more over time than the infusions do, and most insurance programs don't pay for it because it's technically a vitamin. All right, go to the next one. So, this is now you're now in Ray's expertise. This is a very complicated formula about how much iron should be in the body of an infant, a child, or an adult. You can pull that down. And then it used to be, to get that iron, to get that thing worked through, you had to have a slide rule because it's a lot of stuff to it. Ray came along when they had slide rules.
Slide rules were going out of favor right as I came into engineering. So.
Oh, really?
Yeah.
We had slide rules when I was, because I'm a lot older than you are. All
You
right.
probably had a little hook on your belt.
I did, and I had a K&E. K&E, that's like the Cadillac of slide rules. It costs several $100s. You can buy a computer now for what my slide rule cost in 1956.
Yeah.
Amazing, isn't it? And that was expensive, wasn't it?
Yeah.
Okay, now, that is got the next one up there? Calculation of parenteral iron dose for treatment of adults with iron deficiency. That's 2 pages long of calculations. I'll just give you a really quick. It says if you got a 60-kilogram woman, that's about 132 pounds, with a hemoglobin of 8, and you're using this product, then you take the weight in kilograms, the hemoglobin minus 14 times 2.61 plus blah, 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 pull it down, and then you've got how much iron it takes to get the hemoglobin back to normal and replace the iron stores. So now the hematologist and his pharmacist are not going to follow that formula, because that formula would take iron and put it back in the storage spots, and his hemochromatosis would start coming back. So now they got to sit down and slice out the last piece of that and only put in the amount of iron it takes to go from a hemoglobin of 5 to a hemoglobin of 14. So that's 9 grams of hemoglobin, and then you know how much his body weight is, and there's 65 cc's of blood per kilogram of body weight. And so Ray, with his slide rule or his computer, can figure out how much iron to give to correct the iron deficiency, but not to reestablish the hemochromatosis.
Bill,
So
talk a
it's
little bit
safe.
about how much safer and easier it is to give IV iron now than just 20 years ago.
Oh my gosh. Okay. There was the original iron preparation that we used to use when Ray and I were in training was given intramuscularly, and it could cause a fatal allergic reaction. And the first fatal allergic reaction to that drug was given by a guy named Julian Jacobs, who trained in hematology at Emory and who became the chief of hematology at the VA, and he was a first-year hematology fellow when he shot that thing in that guy who had an anaphylactic reaction and died. So Julian became famous. But anyhow, it was real serious in those days. So the drugs now are hypoallergenic. Some people, when they were getting, might get a little chill or something, but it's much, and there's no pre-medication required. And this is something else. We talked about insurance before. We're going to talk about Medicare again in a minute. Plain old garden variety Medicare pays for Integra, which is you get 2 infusions a week apart and you're finished. And every blanket insurance company does not pay for Integra, and some of them make you use a product that requires 5 IV infusions at weekly intervals, or 7. And does it make any sense to do something 5 or 7 times? You could do twice. And that's all the baloney about insurance and contracts with manufacturers. And that's a part of medicine that Ray and I both
Rail against.
I was going to say hate, but that's a lot better word. Okay, so that at the end of the day, the answer to the question is, will taking IV iron hurt him? And the answer is absolutely not. And the hematologist is doing the right thing. You would not be able to give him enough iron to get him where he can get his abdominal aortic aneurysm surgery, because that's an emergency or urgent. This is like a bypass. So this is not like a facelift. This is something he needs, and he needs it immediately, obviously. And so you can give him all the iron he needs back in 7 days. You can operate on him next week and quit worrying about the iron level.
Let's back up and go into some primary care aspect of this. So this, I keep marveling at, he walked in with a hemoglobin of 5.
He got there slowly, didn't he?
Yeah, I got there very slowly. I mean, he's got a third of the, slightly more than a third of the amount of blood or red blood cells that he needs to oxygenate. And so, I'm not marveling, like, how is this guy functioning? Is he not feeling something? What did he miss? Because I want my patients to come in when there's something wrong. To talk about what he should have been feeling or what he was ignoring.
Well, first of all, if you look at this, patients that have sickle cell anemia, full sickle cell anemia, never have a hemoglobin of greater than 7 or 8. So they live with it. I mean, they're out in Africa,
Right.
They're digging ditches. So they have equilibrated to it. This guy has become anemic over the long haul. His plasma volume is normal, so his blood volume is normal. So he doesn't
Right.
drop his blood pressure.
Right.
It did say that he was, what did he say, somewhat lightheaded. Well, I mean,
What do you think would happen to him if he went out to Colorado and started trying to ski at 10,000
He'd be short of breath.
He'd be passing out.
He'd be short of
Yeah.
breath, and he'd be really sick.
yeah.
But he's obviously not got coronary disease, because with that hemoglobin, he'd be having angina and congestive heart failure if he had anything wrong with his heart. So we see this frequently, and it's not something that I'm not used to seeing in my office several times.
Well, you see a
month.
lot more than the average Joe.
Of course, it all filters
to you, but I'm just talking about people walking around. So
most
you'll see
people
a
walking
doctor
around would be short of breath when they walked upstairs.
Right.
And they would have rapid
pop
heartbeat,
up out of
walk
bed,
across
and
the parking lot.
Yeah. And if you pulled their lids down and looked at them, they
pale.
wouldn't have a very pink inside of their eyelid. They'd be really pale.
Well, now that's when your grandmama used to say, "Stick your tongue out at me,
Yeah.
boy," and it wasn't pink. What'd they do? They gave you a dose of salt, or they gave you castor oil. You're too young to remember either one of those. But anyhow, so
I'm
that's
too young to remember.
That was a.
We're going to have a too young to remember question in a minute. I got a couple questions.
Go
Am
right
I gonna
ahead.
get to my
Your turn.
questions?
Yeah.
In the 70s, why did doctors in the 70s tell you to eat liver?
It had a lot of iron in it. It had a lot of other nutrients.
And B12.
Huh?
B12 and iron.
Yeah, but
back before they discovered B12, that was the only way to treat pernicious anemia.
my sister, that's in the 70s, my sister, the doctor said she had iron deficiency, and he told my mom to
feed her liver.
Once a week have liver.
Yeah.
Just
We
wondering.
used to try to hide the liver under the edge of the plate so you didn't.
Exactly. I'm thinking, wow, I didn't like that. And let me just clarify
Well, that
something.
wasn't done with a lot of gravy and onions on top.
It don't matter what you smother that liver with. It's not done for me.
You don't like
you
foie
can
gras?
you can smother that liver
You don't
from
like
here to next
foie
week.
You don't like foie gras? A piece of foie gras that size right there costs about $75.
Yeah, okay. All right, anyhow.
That's liver.
Did I hear you correctly? Let's go back to vitamins, because it's a big world out there. People take vitamins in the morning.
They do.
Did I hear you say not over-the-shelf vitamins with iron or whatever? What did you?
We shouldn't generalize, but
And that's why I want to be clear. Like,
well, what I tell most people is if they're eating a good, well-rounded diet and plenty of fresh foods and vegetables, that they don't need a vitamin. Okay, you're just making expensive urine. You're pissing most of it off, and you don't need it. But there are some people that need a vitamin, and the doctor should tell them about it. But Bill brought this up several months ago, and I've been thinking about it ever since. And I don't know whether I'm just focused on it, but have you noticed that every frickin' commercial that comes up now is somebody pushing some powder or some pill that's going to make your life so much better? It's like
Grind up vegetables and stick them in a capsule.
the fruits and vegetables you can get in a pill, or you can get in a powder, or you can get in a drink. I'm like, well, just why don't you go out and eat right? And why in the world are we just totally into these powders, which they act like, well, they're fresh? Well, there ain't nothing fresh about a ground up powder that was desiccated plant.
A, it had to be dehydrated. It had to, or
You've adulterated as much as you can adulterate.
Right, and then you had to grind it,
Yeah.
and then you had to put it in a container.
But it is wild out there. The number of people making fortunes
And when
off
that
of
gets
selling
in your
this stuff.
stomach, it's just a fraction of what you would have had if you'd had a little cup of broccoli or a few pieces of
Yeah,
asparagus.
so I mean, it's a wild thing right now. A number of people pushing these nutraceuticals. It's just crazy.
I like that nutraceutical. That's a good word. So
Good,
anyway,
agree.
they answer the question. The guy should take the iron and then go get his aortic. The aortic aneurysm is the issue, and why is he anemic? Now, he might have colon cancer. He might have gastroesophageal reflux. They'll have to find that out immediately, but he's got to get the iron first.
Folks out there, the grand prize winner today is the one that can send me a message and tell me the count. How many times he said iron. If you counted how many times he said iron in the last 20 minutes. Go ahead.
Is that like that bowl of M&M?
Yeah. If you can count how many times Dr. Whaley
All
said
right.
iron.
Now, BKP was listening to this question, and he was appalled at parts of it. My brother is 52 years old and has smoked since age 6. He has been in prison off and on for all of his life and has had hepatitis B, tuberculosis, and other prison-associated diseases. Now, he has not had preventive medical care.
No. He had no medical care.
He has not have.
I want to know, are you the older brother? I'm not trying to get in trouble here this close to Christmas, but your brother's 52. Who is the older brother that gave him his first cigarette at 6?
Well, you might be the younger brother.
Just asking. Go ahead.
You might be the younger brother, but this is really important. We know, though, that in prison, they test you for hepatitis A, B, and C. They test you for tuberculosis, and they periodically do that. He's had at least those 2 diseases. They don't go around testing you for cholesterol or diabetes or anything unless you got that diagnosis. So must be out of prison now, because he has a huge right-sided adenocarcinoma of the lung. That's important. That involves his mediastinum and cannot be operated on. He originally refused to think about treatment. Probably, I'm sure he doesn't have insurance either. But he saw an oncologist last week who told him that he had a MET gene and might not need chemotherapy. He's doing more tests. Now, this is really important. The doctor that diagnosed him said he had to have chemo and radiation. Question is, what is MET lung cancer? Let's back up. The doctor that diagnosed him said he had to have chemo and radiation. Now, we have talked about this exact this exact stage of non-small cell lung cancer here 3 or 4 weeks ago. And at this stage, which is going to be 3B if he doesn't have disease somewhere else, which I'm sure he doesn't, or he wouldn't have made this decision about chemo radiation. And he needed to have chemo radiation because this is a non-resectable tumor that's in the lung and invading the area of the heart, and the only way to attack it in terms of local control is chemo and radiation therapy. I'm confident that the thoracic surgeon or the pulmonologist who diagnosed it didn't have the genetic tests and the other tests that the oncologist has been able to get. So when the original diagnosis was made, they gave him the right advice. When he was sent to the oncologist, that means that the oncologist has now got a couple of weeks after the biopsy to get the pathologist to do some tests, which we're going to talk about in a minute, and the diagnosis is still the same. Can't be operated on, can't be removed, but he might not have to have chemo radiation therapy because of this MET. All right, you ready? So let's go back. Now you've seen this 15 times. The thing we're talking about is non-small cell lung cancer. If it's non-small cell lung cancer, then there must be another one called small cell lung cancer. Pull that down. So remember that non-small cell lung cancer starts in one spot, slowly grows out, and so it's like you dropped a pebble in the pond and the ripples slowly rippled out. These ripples have rippled way out and gone all the way to the heart, so they're at the shore. And small cell lung cancer is like you throw gravel up in the air and starts in a lot of places at the same time and is generally never treated with surgery or radiation. Put up the next one. So we go back, there are 3 different types of non-small cell lung cancer. Adenocarcinoma over here, squamous cell cancer here, and then large cell cancer here. There is a difference where they begin anatomically in the body. And squamous generally begins in the bronchial tubes from really heavy smoking. Adenocarcinoma, you can pull that down now. Adenocarcinoma is the most frequent form of cancer of the lung, and this is the one that occurs in more females than males, non-smokers. So a non-smoker with lung cancer generally is adenocarcinoma, and it's common in Asian women. Well, this guy is as far from a female non-smoking Asian as you can get, but he has adenocarcinoma. So put the next one up. So this particular stage, going back to the kind of the cartoon, and you look at this, it doesn't. You don't appreciate when you see a cartoon like that this thing does what it does. So put up the next one because I think it's a beautiful picture. This kind of bright yellow orange thing here, that's the lung cancer. you'll notice this big thing in the middle. What's that? It's the heart, right? You're used to that. You've seen a lot of chest x-rays. Well, you can see that this goes right up underneath the heart and wraps itself around these breathing tubes and big old arteries inside the middle here, and there's no surgeon in the world nowadays that would try to get that out. Pull that down. If you read that book I mentioned a few weeks ago called The Emperor of All Maladies, they used to try and remove that in the 60s and 70s. So, many of these patients have obstruction, have pneumonia, they wheeze, and the only thing that you can do with them is if you give them chemoradiation therapy, within a week or two, you can stop the wheeze, you can shrink the tumor down, and do a whole lot. So put the next one up. This picture you saw a couple weeks ago when we were talking about prostate cancer, of the way you take that, I think it was last week we were talking about rectal cancer, and you give 6 weeks of treatment and every day is a different direction. Well, that's exactly what you would do with the chemoradiation therapy of the lung. So y'all are used to seeing that. What you got here, BKP?
Survival curve.
This guy is in this bottom line right there. That's not so good, is it?
No.
This is 10% survival right here. Mm-hmm. And this is 2 years, but it's down below 20% at a year, isn't it? All right, pull that down. So they asked about MET. BKP and I have been doing this program for about 5 or 6 years. And at the outset, way back when, I said in the future we're going to be treating cancer not based upon its organ of origin, but on its genetic profiling. And in the last 2 or 3 years, we've treated breast, ovary, and endometrial cancer based on presence or absence of the HER2 new gene and so forth. We are treating many solid tumors now based on the gene that's driving the malignancy. And these, put the next one up. So you'll remember over here on the left-hand side is EGFR. That's epithelial growth factor. You remember back when I talked about the seed in the ground and the sun, and it goes up and it goes down? When we started this 5 or 6 years ago, the only markers that were routinely findable was that one and the two on the left. If you look at this now, there's 20 different markers there, all of which have been found in the last 3 to 5 years. And this is the breast cancer marker. This MET is right up in there. Now, you don't care about all these flow sheets, but when you get down near the bottom, these things make the cancer proliferate. They make it resistant to the natural cell death. They create, that's the EGFR, the thing that lets the blood vessels go. And so they all have a different way of promoting the growth of the malignancy. Okay, now pull out the next one. Got the next one. Frequently we've talked about this patient had cancer 4 years ago, and now he's got a spot in his lung. It's too small to biopsy, and we talk about doing a blood test, a liquid biopsy, meaning that they're going to be looking for fragments of RNA or DNA in the blood. They're not even going to stick a needle in that thing anymore. Or we say now he's got a spot in his liver, it's big enough to biopsy, they're going to biopsy it. So the point we're making is there are ways to test for those 20 different genes there that can be done on the tumor itself. Well, if the tumor is out and gone, it's difficult. Can be done on biopsy of the spread, but if these are all tiny and microscopic, it can't be done on that, or can be done on liquid. So just to make things a little bit funny, here's a long list of the different genes over here, and it can be done tissue sequencing, circulating DNA, circulating RNA. So there's different ways to go about testing. You pull that down. I don't know whether they tested the tumor or they tested his blood, but this is the distribution of all of those different genes there. And you see this little tiny gray slot right there?
Yes.
That's 1.5 to 3% of non-small cell lung cancers carry that gene. Pull that down. So now you've got a cancer that's more common in females, more common in non-smokers, more common in Asian women, and you've got a gene that occurs in only 1.5% to 3% of all lung cancers occurring in a heavy smoking guy that's been in prison all of his life. So he is really lucky. Now, I'm not going to, if you look at that thing at the bottom where I said it can make it proliferate, make it stop dividing and so forth, there are two things can happen to MET. One is you can have a genetic modification of the MET gene, meaning it's been changed, or two, you can have a proliferation so that the MET gene activity is much higher than normal. So that's two different things in the same gene. One, the gene ain't working right, or two, the gene's working overtime. So there are two MET drugs. Put up the next one. One of them works on overtime, high levels of MET. The other works on defective gene. So, I mean, that's pretty darn complicated, isn't it? All right, pull that down. So now we're going to get into, I do not know, and neither do you, by the question, whether he's in the MET defective gene or whether he's in the MET overworking gene. But if you just look at this chart, if he is in, if he's got either one, he's in pretty good shape, because the average survival, you just look down here, was 10% at 1 year. With the MET drug, what's that say?
24.6 months.
Months. The survival is 2.5 years versus 6 months, and that's just getting started. So this man might need a little chemo radiation therapy if he's got pneumonia with his tumor. Don't know if he does. If he can't breathe and his oxygen low, he might need a couple of weeks of chemo radiation therapy. But if he can get this MET drug, which is $12,000 a month, it will be given. If he has no insurance, he'll get the drug for free, because the insurance company's going to give that drug to him for free. It's a pill. He'll take a pill twice a day. If he's covered by Medicare, is going to have a big deductible, and then he's going to have a donut hole, and the insurance company can't give it to him for free because of the blinking federal guidelines, but he'll get it. And if he's got commercial insurance, you see these ads on TV, it'll cost him $10 a month. So basically, at the end of the day, your brother, if he is willing to take treatment, and he said he didn't want to take treatment, my advice is he takes treatment, gets the MET drug, and you're going to know in 90 days whether it's going to disappear.
Bill, if he's a Georgia resident and he has the diagnosis of cancer, does he get, or is he offered Medicaid? Is that an automatic?
I can't say about the automatic. The answer is our social workers. I would refer this patient to our social workers on the first day I saw him, and assuming that we don't know for sure whether he has income or not. If he does, it might be for selling drugs and it's not been paid because he's been in prison so much. So basically, if he is uninsured and has no income, yes, he'd be on Medicaid within a week.
And I know your company, Georgia Cancer, has a fairly robust indigent program for.
If he just came in our office and had no insurance, he'd be treated for free.
Let's talk a little bit about the evolution of gene technology. You mentioned, and you had the matrix of tests that are done just on serum or on blood versus tests that are done on tissue, where you actually have to go in and get a piece of the cancer, take it out, and run certain markers and look for certain genetic markers in it. You predicted several years ago that we're going to be in this world where gene therapies and gene knowledge will direct therapy.
That's where we are.
How fast do you see that changing? Is that not amazing what's going on?
Well, in 2022, I believe there have been 60 immunotherapies and gene-related therapies that have been introduced. And everybody will remember the Keytruda drug. We always say the Jimmy Carter drug.
Yeah.
That was the first one to get widespread advertising or community knowledge. But it used to be that we said that carboplatin and Taxol were the broad spectrum antibiotic of oncology because we gave it for breast, lung, lots of different cancers. That Keytruda is sort of the broad spectrum antibiotic of oncology now, and is given for kidney cancer and lung cancer and all kinds of cancers. And that this technology changes roughly twice a month. And our group meets once a week to look at what's changed. And adding new drugs each week, we probably add 1 or 2 drugs each week to our armamentarium. So it's changing so fast. Massively fast, yeah.
I mean, I look at the dichotomy in our world, the technology changes, particularly in the area of cancer and biochemistry, that are advancing knowledge and survivability and tolerability of treatments. All those things are just
Amazing.
And then you look at the public health, which was basically functioning at caveman speed, which has now gone into the dark ages. It's gone completely the wrong direction. I mean, we're almost schizophrenic in our world of medicine and trying to deal with all the change that's afoot.
Well, Ray and I were talking in the green room back there about the deficiencies of our, and I'm on the county board of health. So I work with the state board of health. I'm not, but the fact that they added how many COVID deaths have there been in Fannin County as of the last 8 weeks? 175. 175.
Total. So it's, yeah.
What's it say right here? 178.
Right.
In 1 week they added 3. Well, there haven't been 3 this week. I don't know of any this week.
Grave robbers.
That they've gone back. I mean, these numbers now are just, they don't mean anything. But,
all right. Do you have some news of the day?
I do.
We lost 3 minutes. Our fault, but we got to get you to work.
All right, okay, all right. So yeah, we got news of the day.
And his suspenders will only last so long.
One flesh-eating bacteria is back, and it is a huge. There have been 60 cases in Ohio in 4 weeks. So if you get that big red thing and you cut yourself out in the lake, that's one. The second thing that Ray and I are against is bad advertising. Tell them about the Medicare Advantage.
Well, the Medicare marketing is over as of, a couple days ago. But we've been barraged
It's
with...
just the 14th or something, wasn't it?
Yeah, it just ended. Anyway, we've been barraged with just BS, constant nonsense from all kinds of insurance companies trying to sell you their product, where they're basically nuancing how much money can they get out of you and the government and not give you care and services. So I said to Bill, these are chess masters and you're a checker player in their world. So buyer beware.
So anyway, I don't like our federal government. Yesterday, they issued a directive that limits deceptive Medicare Advantage advertising. And you have all seen Medicare Advantage ads that say, get a larger Social Security check by calling this number and signing up for Medicare Advantage. They don't tell you the name of the company, whether it's Cadillac or something you've never heard, or what the benefit is, but it's true. You would get about $15 to $25 more a month on your Social Security check if you signed up for them, but then they wouldn't pay for most things. And that's just deceptive advertising. And most of the people that have done that are relatively poor because they think they're going to get eyeglasses and dental care. They're just not going to get drugs and surgery, or the disabled. So anyway, that's a huge thing, and it's not too late.
It's fraud and deceit.
It's fraud and deception. Okay, that's enough. Got it? Well, how about the intermittent fasting one?
Well, okay, that's a good question.
Tell that for BKP.
Yeah, go ahead.
Well, there's some news about if you do intermittent fasting that maybe you can get rid of your diabetic medicine. So maybe you can, but I'm for discipline, and fasting requires discipline. And I think intermittently fasting, that is being more normal in your body, where you go for hours at a time without eating. You get hungry. You let your body go through cycling all those on and off switches that it has to do. That's a healthy thing. But the bottom line is that if you do lose weight, you can make your heart disease better. You can lower your blood pressure. You can lower your blood sugars. You can feel better. So weight loss is a good thing.
And it doesn't make any difference whether you did that by a low-carb diet
Yeah.
or walking for an hour every day.
Right.
But anyway, so that's what the news was.
All right, I
about
have two
intermittent
quick
fasting.
questions.
Yes,
Two
sir.
very quick
All right.
questions. One for each of you. One, you're wearing suspenders. Do you have to call in a whole team to get this
I do.
ensemble
I
going?
do.
I mean, how many people does
Well,
it
I've
take
got
to get the,
it's cold,
the suspenders?
and I wore my lined pants today, and
Okay.
you know I got droopy drawers, so I got to keep them up.
Okay.
Yeah, that's what's
Whole
going on.
entire team
Yeah.
has to get together.
But I
That-
guarantee
that's
you,
your question.
maybe his underwear was bought by
right.
himself,
Yeah.
but everything else came from the boss.
Okay, now your question. You're always discussing when you started in, medicine. You're always bringing that up when you started in medicine.
You just have to crank the car with a crank.
No, what we want to know is when you started in medicine and you went to the office, where'd you park the horse and buggy?
That's right, exactly what I said.
Those were my two burning
That's it,
questions.
That's it.
Yeah.
No, it wasn't
Suspenders-
horse and buggy. They had cars that cranked in the front then.
Yeah.
They had cars. Yeah.
Okay, and then jump in. Okay. Thank
Have
you.
you-
They always parked on a hill.
Well, I'm
on the hill.
serious. Wait a minute, I'm serious as a train
All
wreck.
right.
Have you ever cranked a car up?
No.
Have you ever seen one?
Yes.
I actually had that. My family had those cars, my uncles and stuff, when I was a boy. It was 1940. And these cars were to the 20s and 30s, and batteries, they had batteries and hand cranks. So that's
Well, I can do
old.
better than that, Bill. For my entire sophomore year of college, I had a car that was up on cinder blocks while I was repairing it. So
Thank you, Georgia Cancer Specialist, Northside Hospital Cancer Institute, for our segment. We apologize for our brief technical issue today, but we're well on our way. We have the All-Star Political Panel coming up next. These guys, I never know where this guy's going. He has to go to work. That's a nice tie.
The
Merry
chances
Christmas.
that we'll be here next Friday are zero.
Zero chances. What about snow? I mean, you being here is one thing. I'd rather have snow for Christmas. Sorry.
I don't know about snow for Christmas, but you might have it tomorrow.
Tomorrow?
Yeah.
if you want snow, go to Minnesota.
Minnesota, snow, so much to report here. We'll be right back.